On-the-scene video coverage of TCT 2012 is supported by Prasugrel.
I'm happy to present to you the angiographic cohort from the TRILOGY-ACS study on behalf of my co-authors and the co-investigators. These are my disclosures and some of my co-authors. So despite the fact that we're at the premier interventional cardiology meeting in the world, it's important that we recognize that a large proportion of patients, up to 40 to 60% of patients with ACS, are managed without PCI. This can happen in two ways. Patients can be triaged to medical therapy after they have an angiogram, and patients are triaged to medical therapy without angiography. Both sets of patients were enrolled in the TRILOGY-ACS study, which compared Clopidogrel to Prasugrel, a thienopyridine P2Y12 inhibitor, which had been shown to improve ischemic outcomes in patients who were treated with PCI in the Triton-TIMI-38 trial. This is the primary result of the TRILOGY-ACS study that was presented at the European Society of Cardiology earlier this year and published in the New England Journal of Medicine, which showed overall in this medically managed cohort there was no difference in the combined outcome of cardiovascular death, MI, and stroke, and although numerically higher, no difference in major bleeding with Prasugrel compared to Clopidogrel. So we sought to understand whether this was the case for patients who were managed both after angiography or triaged to medical therapy without angiography. On this slide, you can see how patients flowed into this study. The primary population was those patients under 75, and there were 7,243 of those patients. 43%, or just over 3,000 patients, had angiography and then were triaged to medical therapy, while 57%, or just over 4,000 patients, were triaged to medical therapy without angiography. And the comparison is made within each of these groups between those treated with Prasugrel or Clopidogrel. Now, comparing the outcomes between patients who had angiography and those patients who didn't have angiography, we can see the results on this slide. And what you can see is that overall event rates were higher among patients who were triaged to medical therapy without angiography. You can see 16.5% compared to 12.8%. This difference was largely driven by a difference in cardiovascular death, with higher rates of cardiovascular death seen among the non-angiographic patients and relatively similar rates of myocardial infarction or stroke. Similar finding was also seen for all-cause death, and then you can see here that rates of bleeding were somewhat higher, interestingly, among patients who had angiography. Now, this is the result of the Prasugrel versus Clopidogrel comparison stratified by angiographic status. You can see on the left-hand side of the slide that patients who had angiography and had coronary disease confirmed had a 23% relative risk reduction with Prasugrel compared to Clopidogrel, which was statistically significant. On the right-hand side of the slide, you can see the subjects who did not have angiography, and you can see there was absolutely no difference in the outcomes among patients treated with Prasugrel compared to Clopidogrel. Similar findings were seen for recurrent myocardial infarction. Here you can see a 26% relative reduction in myocardial infarction seen among patients who were triaged to medical therapy after angiography, and no difference in myocardial infarction in patients who had no angiogram prior to enrollment in the clinical trial. On the flip side of more intensive antiplatelet therapy, we can see that patients who had angiography had higher rates of bleeding, while there was no statistical difference in patients without angiography. When looking at a more sensitive measure, TIMI major plus minor bleeding, we did see excesses in both arms. So in conclusion, we see that there are substantial differences among patients triaged for medical therapy with or without angiography. I didn't show that here, but you'll see in the presentation this afternoon that they were geographically different, with more Western patients treated with angiography, Patients were more likely to have non-STX segment elevation myocardial infarction, and they had higher rates of cardiovascular events, particularly death. Overall, there was no difference in outcomes among patients treated medically with Prasugrel compared to Clopidogrel. However, those triaged angiographically tended to have lower rates of the combined endpoint. They had lower rates of MI and CVA alone and higher rates of bleeding. And although this is a hypothesis-generating subgroup analysis, it is consistent with previous studies and suggests that when angiography is performed and coronary disease is confirmed, the benefits and risks of antiplatelet therapy exist whether patients are managed medically or PCI is elected. Thank you.
Thank you. Thank you, Steve. A very intriguing result. Any questions from the press? Yes, please.
Crystal Fenn with MedPage Today. Were you able to control for the geographic differences? I'm assuming that there could be a lot of things different about the care in Western nations comparatively.
Yeah, so that's a good question. I think that you'll see in the presentation later today that there really is a substantial difference in the way that people entered the trial based on their geography. For instance, in North America, about 85% of patients had angiography before entry, whereas in Central or Eastern Europe, only a quarter of patients had that. When we look at this outcome and we do correct for regional differences, the results persist. So we think that this isn't purely a regional difference outcome.
Okay, thanks.
So go ahead, Lynn.
So I apologize if this is not a great question, but so if you aren't going to do angiography, doesn't matter what drug you give, but if you do, you ought to give Prasugrel. And does that mean that you're doing any damage from the angio, and that you are, therefore, you need Prasugrel as opposed to Clopidogrel?
Yeah, so I think that's an interesting interpretation. What I would say is that this is a study in which the patients entered the trial after that decision had already been made. And so my interpretation is that patients who have angiography and for whom the coronary disease is confirmed, that even if you still choose to manage them medically, that there is benefit from more intensive antiplatelet therapy. I think it's likely that these are just different populations of patients, both in their demographics and the likelihood that the ACS event was related to coronary plaque rupture and therefore amenable to antiplatelet therapy, as opposed to any cause and effect related to the angiography itself.
So I think it's a very important caveats that we have to underline here, especially for the press. First of all, that the overall trial was a negative trial, and whenever you look at a subgroup, even if it's positive, as you pointed out very nicely, it's only hypothesis generating. Furthermore, your P interaction term was always not statistically not significant. So although you're seeing the benefit, there's not a statistical significant P interaction, which I think is extremely important. But all of that put aside, I think these are intriguing findings, and that would you now say that all patients that you're thinking about even medical therapy should at least have their anatomy checked, because maybe we can tease out the patients who may benefit from these more potent agents, or is that just a total overkill? Because I'm an interventionalist.
Yeah. So I would echo your initial comments. I think this is a subgroup analysis of a neutral trial. It does not suggest that we ought to be treating patients in a specific way with a specific drug. I think that can't be stated from these results, and that ought to be clear. I think that what the complicating issue here is that we are not randomizing patients to an interventional strategy or an angiographic strategy followed by treatment. I think what it tells me is, as I tried to explain a little bit before, is that when we see patients in the clinic, if we decide that a patient has the real deal, in general we send them to angiography. Sometimes after angiography, the coronary anatomy is too complex. The patient doesn't want to have a percutaneous intervention. At certain centers, they don't do percutaneous intervention, and there's necessity for transfer, and they don't wish to be transferred. I think in those circumstances, it suggests that there is benefit from intensive antiplatelet therapy. But I don't think it means we ought to be rushing people off to the cath lab who we wouldn't otherwise.
Okay, I tried. 2 questions from the Dean. Did you want to say something
Steve,
related to that?
Yeah, very much so. To me, Steve, it looks like a 2-tiered treatment risk paradox, meaning A, the decision to withhold angiography was made based on X, Y, and Z reasons. B, the decision not to PCI may be anatomic reasons, could be phenotypic reasons, could be like Murat's cohort C, patient just doesn't look like they would benefit from anything. And last but not least, historically, I'm fascinated because the benefit of dual therapy has historically been linked to the performance of PCI, particularly stenting. And here is a medically treated group. It almost appears like it's a symptomatic charisma patients where there was benefit. These people are for real. They got real disease, they were symptomatic, and they showed benefit. Could you respond to that?
Yeah, I think that's. I think you've stated it very well. In my opinion, that the performance of angiography, that when we're taking care of patients clinically, we often decide that sometimes patients are too sick to even take to angiography or are too complicated, or we think that the disease is unlikely related to coronary artery disease. Patients can come in, have ST segment depressions, have even small elevations of troponin related to complex phenotypes as you described. So I think that you're probably dealing with more than one group of patients in here. But my sense is that when you look at this in combination with the Plato non-invasive data, which was a different cohort, but still, many patients in that population didn't have PCI but did have angiography, and there is a benefit with a different drug with intensive antiplatelet therapy, that I think there is a population of patients who don't get stents who still benefit from P2Y12 blockade.
We just need to find them, and I don't know how. And maybe
make it short.
Dr.
Okay.
Silver, last
I know
comment.
we're late. The one slide you showed that the curves separate after angio and do not separate with angio. I assume that some patients having angiography got PCI, not too many, but some got. But I understand the separation of the curve. But why after 1 year? That doesn't make sense. If those got PCI after angiography, the curves should have separated earlier.
They didn't get PCI.
So these patients did not get PCI.
Not at all,
right,
but there was some
medically
crossover.
managed.
Right, after
They were all medically
angiography,
managed.
they had a decision to not have PCI.
But then it doesn't make any sense.
We're trying to understand.
Yeah, so I think that what we're seeing also compared to some of the other studies is that patients had angiography and could be enrolled as late as 10 days after the angiogram, so that these patients may not have had as active ACS at the moment of enrollment, and so you're identifying a population of patients who will benefit over time.
Thank you so much. I'm sorry. Dr. Wiviot will be available for any more comments. I really am going to get fired from this job. So
I will
doing a good
I will
job.
hire you, okay?